Okay, so we have two great presentations lined up today. I want to introduce first Robert Stiles to take us through the Telehealth ROCKS project from KUMC. Robert?
Great. Thank you so much for having me today. I was trying to think the last time I presented, and I think it was about 4 years ago. A lot has happened since then. Sorry, let me get my slideshow started. There we go. We'll get there. And a lot has changed since then, including what Telehealth ROCKS is. Telehealth ROCKS is a program that started way back in 1995, beginnings, and then in 2015 got some federal funding, and it really focused on, it's a program in the Department of Pediatrics and specifically of behavioral pediatrics here at University of Kansas Medical Center. But we had always really focused on clinical services, behavioral health services, especially making those available to school districts. And that even meant we changed our name. So it's Telehealth ROCKS, and telehealth and the digital side of things is important to us, and that's one reason why we're here today. But the ROCKS has really turned into a different name, which stands for Regional Outreach for Communities, Kids, and Schools. So when we think about what brought and keeps this coalition together, and we'll talk a little bit about our partnership, what brought us and keeps us together is really what's in our name, communities, kids, and schools. That's what we really focus on. And so when we think about our collective vision as a group, we really focus on this idea that we believe that schools and communities where every child has the resources and skills they need to have the exact same opportunity for success in school and in life. That's what we're about. That's all. We'll do whatever it is that gets us there because we believe it's really important. So we began to work as we think about our mission and how to lead into that vision. And really it comes about from this idea that we need to transform our communities, that we believe that they're comprehensive and we have to have comprehensive and integrated approaches. So partnership is incredibly important to us to both amplify existing resources and develop new solutions to meet the needs of kids and their families throughout the country and the world, actually. So why do we need to transform our communities? We've all seen this model of health, and we sort of give lip service to the idea that only 20% of our health comes from healthcare. But when we really think about our communities, you've got 40% socioeconomic, that's community related, 10% physical environment, that's your community. But even the remaining 50%, your health behaviors, which is 30%, are impacted by your community, your access to food and diet, and so many different things, as well as your access to healthcare, really come about from the community. So if we're going to make a world where every child has the exact same opportunity, where we're going to impact behavioral health so we don't have to do clinical services, so kids don't need therapy or other interventions one-on-one, then we've got to really impact and change our whole community. So what does that mean when we talk about our program? So we focus sort of on four main areas, which is clinical services, which are offered through telehealth and other means, training, which we do often using the ECHO model, which comes out of New Mexico, student prevention services, which are some of these universal interventions, as well as engagement and family support. But students and families are at the center. We do make use of community health workers. We use school-based community health workers in our work. And our goals are that everything be developmentally appropriate, equity-based, recovery-oriented, trauma-informed, evidence-based, and culturally relevant. So what does this really mean when we think about what are the key concepts then? So our program is school district driven and centered, especially when we talk about the rural areas that we serve. School is central. It's central to the rural community. When I first started putting clinics in schools in Southeast Kansas, then I moved to Missouri, what you find is often the place that a community has that even if they don't have a lot of other things, there's a school. And it's a place both where we can access kids because that's where they are, but also support their families. So we believe that everything should be universal, targeted, and individual, that there should be a spectrum of what we do. Our clinical services, but we also focus on the social determinants of health. And we see that as a behavioral health intervention, along with support for those others working with children and families. We're trauma responsive. We want to mitigate the impact of trauma. We're working to reduce its occurrence. There we go. Focus on the training and resource needs of schools, clinicians, and communities. We really believe that one of the best ways to use telehealth and all of the digital opportunities available to us, and the way to get the types of services and the amount of services and the amount of interventions that we need in our local communities is through developing the local community and supporting the local community, whether that's clinicians, behavioral health therapists in the local community, pediatricians, family medicine doctors, or supporting school districts who have a number of specialists, school psychologists, school counselors, special education. But we also believe that our school districts, our clinicians in our local communities, they're the ones that should tell us what they need, what they're struggling with. And so we really work hard that our training and our support that comes out of behavioral pediatrics here at KU School of Medicine, along from other partners, that it be responsive to what the local community is saying. Collaboration and creation of integrated systems, right? It's about the entire community. It's about bringing everybody to the table. One of the things that I say a lot is, there's enough going into the system. We have enough resources in the system. We don't coordinate them. So we talk a lot about coordinating, not creating. We only create when there's something that's missing, that's not available, that's needed to make the system work better. And then we have a new focus, or have begun to develop focus beyond sort of generally supporting all kids in the community. Really begun to find some work and are excited to begin to focus on some youth and families that have specialized needs, groups like immigrants and those involved or at risk of the justice system, those involved with foster care, protective services, and intellectual and developmental disabilities. So what have we learned? We have to collaborate, and then everybody has an equal voice. We went, it's been about 6 months ago now, to a model, sort of a board-based model or a board idea model where every organization has the exact same voice in what we do. And we really believe that everybody's at the table together, has an equal voice. I don't know the answers. Nobody knows the answers. We're figuring them out together. We have to simplify. It's a lot of people in our coalition. So we have to bring everybody together, and we can't confuse things when we have so many people involved. So we have to do a few important things together. We've got to have everybody. We don't have enough now. We'll never have enough until we have everybody that impacts the life of a child. Have to have capacity. They have to better meet local needs with the same level of existing resources. We can't ask people to do more. There is no more, whether it's our teachers or our clinicians. So we have to figure out how to do it better. We have to figure out how to replace things that are currently not working as well with things that work better in the same amount of time and money. But we also have to come up with new solutions and add new resources where needed. It has to be coordinated. We got to understand the landscape. We have to listen. Who's working on it? What are they doing? And those things that work, we're going to magnify and expand them. And we're going to do that before we create something new. A lot of our work is really expanding work that others are doing. For example, we're taking a program that works really well in Johnson County with youth involved with the juvenile justice system. We've just moved it, are doing support for it in Fort Scott School District and the Pittsburgh School District. We got to focus. Each school and community is different. So we got to think about specific needs and issues and develop specific and relevant resources to meet those needs. And it takes all of us. It's got to have schools, mental health, clinicians, federal agencies, state agencies, local community. It's got to take everybody. So here's a brief idea of our timeline. We first kind of got funded and came up with the term Telehealth ROCKS in 2015. We got $1 million in April of 2020, which is really when we began to kind of change or magnify what we did. We do everything we've always done. We just do a lot more. And then you can see we got additional funding. So bottom line, we have $2.7 million a year. That's how much we spend on our efforts across these 4 grants. So who's in our tent? When I talk about this partnership and everything that we're doing, the first thing is children and their families, their voice, their needs. On the government level, we work with HRSA, SAMHSA, and the NIH. At the state of Kansas level, Kansas Department of Education, Kansas Department of Aging Disability Board to Aging Disability Services, Department for Children and Families, Kansas Department of Health and Environment, statewide advocacy organizations, DECA, Headquarters Kansas, Families Together, Communities Honoring Adolescent Success in Education. That's the program that works with youth at risk of involvement with the justice system. Foster Adult Connect. Education, Greenbush Education Service Center, which is a statewide organization. And then the school districts we work with are Coffeyville, Pittsburgh, Sedan, Caney, Fort Scott, Labette County, and Parson school districts in Kansas. And then on the Missouri side, the Eldon, South Callaway, and Kennett school districts. The healthcare partners in this are Community Health Center of Southeast Kansas, which is the large federally qualified health center that serves Southeast Kansas. Fort County Mental Health Center, which actually serves 5 counties. And then, of course, the University of Kansas Medical Center. And then in addition, we've added partners, the Crawford County Restorative Justice Authority, which is juvenile justice for Crawford County, Southeast Kansas Department for Children and Families. We'll talk in a minute about a really innovative thing we've done with them, or working with them on. Southeast Kansas Foster Adopt Connect. And we're going to continue working on partners until we have everybody who impacts our kids. So why all this and Digital Drive? Well, when you think about the mission of Digital Drive, first of all, quality of life for all people, equity is important, economic prosperity, and elevating the community. That's what we're about, right? We're going to use the resources, we're going to use the digital resources we have, we're going to create new approaches and uses of technology so that every child, right, that we have equity and the community has what it needs. When they talk about the business model, right, decrease socioeconomic differences. That's our vision. We believe that every child deserves the same exact opportunity for success. So we got to get everything out of the way that gets in the way of that. We use technology to kind of deal with these issues. And of course, are actually developing some emerging technology. So when you look at the Digital Drive model, it's our model, right? We're engaging the community, identifying the opportunity, coming up with solutions, tracking the results, then starting all over until we get it all done. So our values and things that we've really found as we've been at this about 2 years now. This broader coalition and everything that we do, it has to be comprehensive. It has to include everyone. For an example of that is our partnership with Southeast Kansas DCF and Greenbush Education Service Center, where across Southeast Kansas now we've created a school district referral system, so that school districts aren't having to call DCF because the child has unmet needs and the school district's frustrated, helping schools where to go and how to go and link together clinical resources, school district resources, social services. And then in partnership with Community Care Link, who's presented to this group before, a group here out of Kansas City area, is to create an information referral exchange across Southeast Kansas that includes all health, education, and social services. We have to be responsive, locally led and defined, asking what are you struggling with? For example, our Keeping Kids Safe Echo last year, we focused on suicide. This year, because our local communities are telling us that social media and substance use and bullying, self-harm, and disordered eating are high priorities. We've moved into that area, begin to train and do work on that throughout this entire school year. We began to move into the area of youth impacted by the justice and child welfare systems because DCF said, how can we keep them from ever coming to us? The justice system in Southeast Kansas is saying, how can we keep them from being involved with us? How can we keep them at risk? And as we began to work with school districts, especially over the last 6 months to a year, and you can see national numbers that show truancy and attendance, attendance is not the same after COVID. Schools are really struggling with attendance. And so we're looking at new solutions, including attendance-focused community health workers in schools. And we'll just do whatever our partners and communities tell us they're struggling with. Has to be expansive. We got to create new models and resources within the limits of the amount of money and funds and time available. An example of that is our school-based community health workers that provide resources so schools can focus on the educational success of that kid, right? Instead of the counselor and the teacher and everybody worrying about the kid not having food or housing or finding out that their electricity is cut off. There's someone in a school now that can work on that and can coordinate that. We're in the process of adding 2 new pediatric clinical postdoctoral fellows that will be supervised by KUMC, by Behavioral Pediatrics, but they're going to be in the communities we serve. One will be at Fort County Mental Health Center in the Montgomery County, Coffeyville, Independence area. The other will be at Community Health Center, Southeast Kansas in the Pittsburgh area. Just want to point out, there's been a lot of progress on community health workers. 30 plus states now, they're billable in some way as Medicaid providers. And Kansas just had a state plan amendment that went into effect in July. But unfortunately, they're not going to be billable for one of their main employers, at least in rural areas, or their main employers in rural areas, which would be federally qualified health centers, community behavioral health centers, and rural health clinics. Have to be receptive. We gotta, I'm a big fan of saying, we'll try this and figure out why it doesn't work, and then we'll figure out what does. So we got to listen and make changes to meet the unmet and emergency needs. So how does it replace current practices within the time and money available? So with some of our trainings on things like resilience and self-care, we decided we had to really come up with and provide all the resources that were needed to implement the work that we were saying or the techniques we were pushing for. Things like shorter videos and resources and making our website a really huge resource. We were told, your training's wonderful, but not everybody can attend, and I can't show an hour-long video in my staff meeting. So we came up with what are the takeaways? What are the 5 minutes? What are one-pagers? making things useful and making them usable. And then we'll just keep adding resources as we figure out and as people tell us what community needs, and as we talk together and say, how about we try this and decide it. Inclusive has got to take us all. Got to have everybody at the table, everybody working together. And we're going to do a few simple things driven by our local community. Talked about our partners before. We're going to keep adding. We'll never quit adding until we've got everybody at the table. So really, it's simple. We're focusing on the environment, coordinating collaboration across social services, education, and health, the individual, right? We're going to meet individual child and family needs. Community, we've got to create a system that includes everyone who impacts a child, and we've got to make our communities places where every child has the exact same opportunity. And when we do that, we're going to meet their needs, but all children are going to thrive. That's our only goal. That's the only thing that we're going to do. We're not going to stop until every child has the exact same opportunity. So here's a couple of our trainings coming up. I mentioned the Keeping Kids Safe Echo. You can see the topics, and certainly happy to have, if you know people that are interested in attending this, this will be happening as you see throughout the year. Other one is Better Behavior Together, which is focused on practical applications for challenging behavior. We're really excited. That's being co-led by a long-term school therapist, a school special education director, and a community clinical psychologist to really work on solutions and coming up with things. Here's our internal team, which crosses both KU Med behavioral pediatrics, but also has individuals from the University of Missouri, Kansas City, from University of Missouri, and from other places. And then, so why are we up to all this? Because children need our help, and it's going to take all of us, and really hope that it will take you as well, and that always happy to bring new people into our work. So I know that was a lot. I did it in 16 minutes, John. I'm pretty proud of myself. Said about 15 minutes. Hope I just don't know. I think just sort of questions. Is that right, John?
Yeah, let's open it up. I'd like to start if I could. Could you maybe say what would be kind of a representative engagement? What would that look like with a student or a young person?
Well, so we're using a school-based model, right? And what that means is, of course, families, and as the community health workers become more entrenched and known in the community, families reach out. But school is a location where often we understand or see a kid's needs, right? They're coming to the attention of the teacher. They're coming to the attention of someone in the school. And so it is, when we talk about school-based community health workers, I have some personal pet peeves, one of which is we often focus on the health, right? And when we talk about social determinants, we're talking about what are those things that get in the way of their health care, or how do we improve their health outcomes? How do we get their A1C up? And that's great, and it's a perfect usage. But we really believe that the community health worker and all of our districts have school clinics and have therapists, and, nurse practitioners and others on board. But we really believe that we're impacting the health of that community and that child by helping them with whatever their family needs to better meet their needs. And it's very much an education success model. So often these are coming out of needs being identified in the school and being referred to the community health worker, and we consider the community health worker kind of part of the education team in that district. So find out that one of the first things that happened in Coffeyville was a family's house burned down early in our program. And the community health worker was able to coordinate all the community resources and bring everybody together. And within 24 hours, had a place for that family to stay, had beds for the kids to sleep in, had clothes for the kids to wear, and they were back in school, right? First of all, we're mitigating the trauma. And secondly, we're getting those kids back in school. We're meeting their needs so that they can be there in the classroom and as much as possible learning.
Well, that's great. Do the community health workers, they administer an assessment of social determinants? Where does that arise?
We use the Arizona Self-Sufficiency Matrix. Because of we work with and partner with Community Care Link, and they have a great dashboard model, right? Red, yellow, and green. And we've been working a lot actually with a number of organizations here in Kansas City. And I don't know why I can't think of any of their names. And if any of our team can tell me, we've been meeting with them to really understand, especially this model that's coming out of the justice system here, and it's coming out of the justice system in Jackson County, and which is focusing on community meetings and community understandings. And what's great about that is then we're able to both see if people, like families' needs, right, if they're moving from red to yellow to green, but also you're able to look at a community and understand everybody's red on transportation. We talked to the group that works in the Truce Corridor. right? And jobs, and they could see that everybody that they were assessing as they were coming in for their social determinants needs, transportation and jobs were coming up. And so one thing you can do is through understanding what people are getting assistance with, you can understand what you need to change in your community, right? Transportation is always going to be an issue. It's always going to be an issue for kids in schools, especially going to be an issue in rural areas. But it helps us both understand change over time, and are we actually, are our families and the kids better understanding, and this idea of self-efficacy? Do they know where to go? Do they know how to deal with it? Are they in a better place? Are their needs being met? But secondly, yeah, combat. Thank you so much, Chase. So we've met a lot with combat as well as some other groups. Thankfully, here in Kansas City, we try to look at understanding how to do these things. We don't ever believe in creating something new. We don't need to create something new. We just need to understand how to do it. And so we often look to other people and understand how they're doing it. But also, really being able to see our communities and understand what we've got to change about our communities because they're a problem for everyone.
Okay. Ashley, why don't you go ahead and ask your question? Ashley had put one in the chat, which I will get to here in just a second. So how are you identifying the school districts and communities in need? Are you looking at Title I status, average income for zip code served, et cetera? She had to hop off, so that's it.
So we're doing it geographically. Southeast Kansas, outside of Wyandotte County, it has the worst health outcomes, some of the highest poverty rates in the state. So we were fortunate to already work with the Coffeyville district as well as have a partnership with Community Health Center Southeast Kansas. So we're continuing to add districts in Southeast Kansas. Our goal is, we're getting there, right? We have a line across the southern border of Kansas that goes from Sedan to Caney to Coffeyville to Lebec County, so over time, we really believe that we need to, I'm a big believer that you have to have a seamless system. We can't talk about how we changed everything until we have a big enough geographic area that we're impacting, able to impact the needs. So obviously high need districts across Southeast Kansas. And to be really blunt, that's where we have the partners, right? You start a project like this where you have partners that are committed to the project. And we knew the people. I used to work in Southeast Kansas. I actually started the clinic for Community Health Center Southeast Kansas in Coffeyville, started the first school clinic in rural Kansas. And then the Missouri people are districts, high need districts that I knew and worked with when I was in Missouri as the CEO of an FQHC there for 5 years.
Okay.
So you go where the partners are ready and excited to do the work. Adding partners over time has been just, it's been so interesting to see how receptive DCF is. And, they're in a period they really want to change. And juvenile justice, people don't get into juvenile justice because they want to punish kids. They get into juvenile justice because they want to help kids. And so, what we need are the resources. What we need are people coming together, because it does take all of us. And so, I think also the fact that it's dynamically working means, there's enthusiasm, it's working, and that, success is the best motivator.
That's great. Teresa, you have your hand up.
Great, thank you. Yes, I'm glad to hear that you're working with Community Care Link. So if people don't know, that's out of First Call Technology. They do some great work. And talking to them, try to get them connecting to the Lewis and Clark Information Exchange. So anything you can do, Robert, to kind of encourage that connectivity would be wonderful. Also in Kansas, I don't know if you saw that Governor Kelly just announced the $7.7 million grant to Unite Us for a social care referral platform. It's a 3-year grant. So I know they're trying to figure out, how to stand that up. So I think it'd be good to, tag into that. In Missouri, again, Unite Us won about a $10 million contract with the state. So on a by-state basis, you should be able to look at that. Don't know if you're kind of connecting in. I know you're doing the Arizona Self-Sufficiency Matrix and good information there. What are you doing with that information?
Well, we're using it to assess family need, right? And whether, I mean, whether it's successful. And then the sort of other thing we're doing is using that to ascertain kind of what we need to work on in communities, because we're seeing the same things come up right across families. In terms of the research, one of the things that, this is new. We've been at it 2 years, but we got our AWARE funding, which is our biggest grant, which is SAMHSA funding in September, so a year ago, but we didn't really have our full community health workers and all the staff on board until March. And so we see good data coming out of districts like Coffeyville, where we've been at it for a couple of years now and have had community health workers in place. But we certainly have, research GRAs, and a lot of those people you saw obviously on our team are academics. So they're pretty substantial research interests. We just haven't gotten there yet in terms of kind of having, we've figured out what we're going to research. We don't have the results yet.
Great. Yeah, just a quick follow-up question. Are you working with KUC PPR and their IRIS communities throughout the state?
We've had a lot of conversations with IRIS, and we're certainly interested. One of the things, I lived through health information exchanges. I was the director of primary care at the state of Kansas, and health insurance exchanges are great, but until we get them, unfortunately, different platforms, different places information are put. If they're not communicating to each other, we need a global resource. We need some type of overarching resource, and I know that's what health information exchanges do. But I also know, right? It took a long time to get there with health information exchanges. So yeah, I'd love to see. We've got lots of platforms. You've mentioned some of them. We've talked to IRIS about building a bridge between Community Care Link and IRIS, because we think it's important that we know, no matter which system someone's using, that we be able to access and understand who's working with that family, so we can coordinate what's happening with that family.
And then quickly, are you working with the managed care organizations at all, so to supplement the reimbursement?
We're not, Carly. I mean, our partners do. Obviously, Community Health Center Southeast Kansas, they have 7% of all Medicaid in the state of Kansas. When you go to Southeast Kansas, there's really not, obviously the health centers and some others, but in terms of a lot of the healthcare that's delivered, especially the Medicaid population, so they negotiate. We don't employ our community health workers. I don't believe in this is not a KU Med thing. So we certainly support and advocate with our local partners, and obviously, just Friday we had our team meeting, which is all the partner organizations, and KDHE came and presented, and Mark came to present on the CHW state plan amendment. Like I said, we work with, across KDADS and KDHE and Medicaid and KSDE, right? One of the most exciting things that's happening is some continuing funding that KSDE has. They're allowing school districts to use to employ school-based community health workers. So all of a sudden we have it's just a toddler program, and we're saying, okay, how do we help support school districts that aren't really in our program, although they're always welcome to be part of what we do and in our meetings and everything. We want everybody in the same boat. But starting to see others come into this field, which is amazing and wonderful, and school-based CHW is going in every school district in the country. But it's sort of this process as we're seeing this idea kind of grow up and explode and begin to get legs on its own outside of what we're doing.
Yeah, there is hope in sight with Missouri with the health data utility that they're working to stand up. So there is hope.
Thank you, Teresa. I have a question from Amy Garcia here. Robert, to what degree do you leverage the presence of school nurses?
One of the things that has happened in Southeast Kansas, and this started in Coffeyville, when I was there back in 2014, the superintendent came to me and said, the state of Kansas doesn't require a school district to have a school nurse. If I gave you some money, would you employ the school nurse, right? And so we worked really hard to separate school nursing from the school clinic, right? Parents, school nursing is a school function, but that's gotten to the point now where in Southeast Kansas, over 40 districts have their school nursing provided by Community Health Center Southeast Kansas. So by working with, and they have school-based health centers and all the sort of school districts that we're in. So that's, and we're really excited that the head of, we're taking almost 25 people to the Advancing School Mental Health Conference, which is the out of the University of Maryland, but it'll be in New Orleans in December. But our next sort of big team activity across the partners is, KSDE is going to be there, KDADS is going, but we're working on, and so all that to say that I'm pretty excited that the director of school nursing for Southeast Kansas is going as well, because nurses are crucial, right? You can't have a successful school clinic without a school nurse because they're the ones that understand the needs that are coming their way. The whole reason why I put a therapist in school, the first therapist in a school in the state of Kansas, back in 2011, was because the school nurse was coming to me and talking about, as an elementary school nurse, our frequent flyers, right? These kids that are in the nurse's office all the time, and that it wasn't a medical issue. And so I went to my boss, and then I went to the superintendent and said, what do you think about putting a therapist in the school? So that, that was a need identified by the school nurse. And in Kennett, Missouri, the biggest advocate and the past head of the School Nursing Association of the state of Missouri, she's the one that believes in a school clinic. And Marge Cole, who's the school nursing coordinator for the state of Missouri, used to not really think school clinics belonged in schools. And she and I worked together, and she became a huge advocate because this doesn't replace school nursing. None of this replaces school nursing, but it allows them to be the school nurses. Yeah, please go ahead, Amy.
Yeah, let me know how I can help. So,
Absolutely.
all right.
Thanks, Amy. Elizabeth, would you like to ask your question?
Yes, thank you. Hi, Robert. Excellent presentation. Thank you very much. I also want to support the whole nursing, the involvement of nurses in schools. They're critically important. And I'll help out, as Amy will also. So be sure to get in touch. My question is, are you partnering with specialist program solution providers such as See&Me? And I don't know if you know See&Me, but it's a company or a program that was started by Risa Stein. And it's an online program. She doesn't have an app per se, but what it is gathers information about children with special needs and their behaviors and their medical problems and so on and so forth. And it can be updated hourly, day to day. And the way it's used, and she's working specifically right now with a lot of the foster care organizations. So, if a child is in school and they're having a problem, or a parent is taking them to school, the teachers or the nurses per se would be able to go into the program. Obviously, they would have the access permissions to see what some of the latest things are that the child has been going through. So it could be both mental, physical, or any kind of behavior issues that anybody taking care of the child, whether it's a caregiver or school or whatever, would have instant access to their special needs, some of their behavior problems. So are you engaging with people like that or programs like that?
We haven't, no, and I wasn't aware of See&Me, definitely. I think there's a lot of interesting approaches. I've worked sort of on the Telehealth Resource Center side with a number of applications, working on things like asthma or, other areas of trying to keep that, make that information accessible. So, like I said, we want everybody at the table.
So you're willing to have people at the table to come and.
Yeah, I mean, we're absolutely any solution. We need to find solutions, whatever works, whatever coordinates, right? Whatever comprehensively, helps meet the needs of the child.
Yeah, this is quite a comprehensive program. I will send you the link to it, and we'll stay in touch. I'm happy to make an introduction. I think that the program could make an incredible contribution to what you're doing.
Thanks, Elizabeth. Other questions?
I wanted to add in, John, that how important the children with special needs, including children with developmental disability and broader behavioral health concerns, are to the program. We work really closely with our KU PEDS colleagues with that. So it's really helpful to hear what you said, Elizabeth. We're always exploring new ways to help serve that population. But I just wanted to put an underline on that, you know, we're really trying to especially reach children that are struggling.
Yeah, the See in Me program addresses everything. The reason it was started was because Risa has a neurodivergent son who was having all sorts of various types of problems and disabilities and so on. And nobody could, you know, understand what was going on. It turns out he has Tourette's syndrome. People thought it was something else and so on. So I will introduce I'll introduce you to Risa and See in Me. I think is an incredible fit for what it is you're trying to do and doing. I'll make sure that introduction happens today.
Thank you, Elizabeth. Other questions from the team? Well, Robert, congratulations to you and the team. Thank you very much, Evelyn, for joining us as well. We really look forward to hearing more about this as things progress. It's been great to see this work. I know in particular that Southeast Kansas tends to rank at the very bottom, the counties tend to rank at the very bottom of the county health statistics. So you clearly are working in an area of great need. So thank you very much for your work and for being with us today. With that, we have a couple of people who have joined us since we kicked off this morning, and I'd like to maybe have them say a quick word of introduction about themselves. I see Amy Roberts is with us.
Hi, everybody. I'm sorry to join late. I'm Amy Roberts. I'm the program manager for the Kansas City, Missouri Health Department Lead Poisoning Prevention and Healthy Homes Program.
Thanks, Amy. Paul.
Yes, I'm Paul Bashore with Mid-America Regional Council, and I'm just kind of a data management person over here within our research services department.
Great, thank you. Is Ion with us still? Ion is a student. He may have had to drop off. So let's jump into, we've been discussing behavioral health topics, and we have a very interesting solution to look at that with Erin Little of Sisu this morning. Erin, if you'd like to take it from here and let us know about your work, we'd be very grateful.
For sure. And, you know, I hope this goes without saying, but if anyone has questions while I'm talking, feel free to interrupt at any time. I love the popcorn questions. John, thank you so much for inviting us. Also, the Robert, your presentation, we will also be at that school mental health conference down in New Orleans as well. I'm actually down in rural Mississippi right now. So we've been spending a lot of time down in the South, understanding how services for students are delivered in different parts of the country. Just to kind of give a little bit of background of, you know, where Sisu came from and how this all came about. So we are a concept that's brought out of HealthWorks Studio. So the studio is brand new. It's affiliated with the Care First Network. And needless to say, I actually, when I was in between ventures, I actually taught in 64 different schools around the Kansas City area. I was really interested in how, you know, ed tech works and looking at different opportunities. But I actually, most of my career has been in non-communicable diseases and building different interventions for government. So I built some mental health curriculums for Department of State and got into digital mental health, specifically minority mental health during the pandemic. So was based abroad and came back and was really interested in the space and understanding how can we support young people and their families. So originally Sisu was looking at how can you support working parents and, you know, obviously with all of us and what we've gone through with COVID-19, how do we support mental wellness and the fact that we have a huge provider shortage in this country. And so when we were looking at how to build and solve this problem, we actually were looking at schools because many times when you go into the schools, you see there's one counselor, 400 plus students. There's 7 states that have no school psychologist at all. In a lot of rural areas of both Missouri and Kansas, they're moving to that 4-day-a-week system, which creates even more friction when it comes to delivering services for students. And of course, the delays and everything that happens when somebody is an adolescent can be really quite shocking. Recently, CDC actually released a report. 1 out of 5 students tried to commit suicide in the 2021 behavioral risk survey. So needless to say, we decided to build a system that is very similar to how schools do this in their day-to-day. So the whole goal of this is, how do you take that bandwidth? I'm not sure how familiar you guys are with a teacher's workload, but teachers are often, mom, dad, counselor, friend. They're constantly going between these different roles. And the fact that many schools, whether that's the principal, the superintendent, the mental health providers, they're often having to take on roles that put a really high liability on the school. So for instance, let's say that a student gets sent to the office and they fill out a report and they say like, oh, I'm, thinking of hurting myself. Even depending on that situation, even if the student is not a threat to themselves or others, the school is automatically liable for that situation. So we've spoken to a lot of schools that just the amount of liability put on them, the insurance policies, everything else, this has created like a really tough situation where being able to have experts stay in the lane, the educators need to educate, and the people with mental health experience can service the students is really, really important to success. So we use a system called MTSS. Many schools use a system like this to more or less identify and segment out the population. Depending on the stage of support they need. There was a few people on this call that mentioned, students with disabilities. So I actually have 2 students with disabilities in my house that are on IEPs. So this is something I've been really familiar with as a mom, and understanding how IEPs and 504 plans, more or less schools will build a system, and tier 1 supports are, how do you build social and emotional learning in a student population? How do you build resiliency, help them learn how to advocate for themselves, communicate with adults, and really have those building blocks to be able to have critical conversations as they become an adult. But needless to say, those additional tiers of service is really where those, working with students with disabilities, so that'd be like tier 2 service, or tier 3, which is one-to-one support. In many schools, tier 1 services are not done by a trained professional. So when a counselor is doing something like that and they have no mental health training, this is where it can get really, really difficult for a school to know, are we providing the right support? And although in an ideal world, we would love to have the schools refer, those individuals to someone like Robert's team or the Telehealth ROCKS team, that's often not the case. There's many stories of students who are falling through the cracks. And that's often because that support piece of working with a family is where things can get really challenging. So how is the parent or caregiver involved? For instance, how do we gather those consents from a parent? So we've built the Sisu platform to be really minimal in terms of the workload required from a school. But it's also data driven. So the administrators are getting access to dashboards, depending on if the school has like a dean of support services or mental health professionals. But every tier of the school is getting access to a different view of data. So the teacher is getting data, the LCSWs in the schools are getting data, but the parent is involved with this program from the start. And that's a key component of what we're doing. So needless to say, we've built these 12-week modules around different topics. So think of this like a curriculum and TikTok style videos to build skills in teens related to confidence and communication. All of this has really been focused around, we use 2 tools, the Yale ruler system. out of their Emotional Emotional Intelligence Institute, and we also use positive childhood experiences. This is kind of the counterpart to an ACE score of like, how do you build that climate around a student for them to succeed? And so on the parent side, they get access to our family support specialists. They're getting access to the resources as well as our near peer mentors. So all of our programs come with a near peer mentor who's kind of guiding them through the program. They can talk with them, you know, in real time, whether that's during the school day or afterwards, to be able to ask questions. So our near peer mentors are not high school age students, but they are trained crisis interventionists. They can also flag things for the school. So we have a protocol on the back end that allows us to more or less identify what level of risk is a student based on how they're engaging with the platform. It's also not a texting platform. So all of it is done through the platform in a way where like the school has a lot of visibility into what's going on. But on the back end, the administrators are able to understand, okay, we just had a student death in the school. Is the level of support we've provided the right level of support? At what point do we need to dial back or dial up? Those are decisions that are really, really difficult for administrators to know. Because when there are, you know, crises in the school, it's really hard to know, like, okay, how do you actually have that plan? Because many schools do not have a strategic mental health support plan. Surprisingly, even on the school safety front, even if there's plans in place, many times those school safety plans, like in case of an active shooter, are not shared with the entire team. So the superintendent of the district might know that information, but not every person does. So when there is an emergency, oftentimes you find that the teams just don't understand exactly what should they be doing in that situation. This is just a little bit on how digital mental health has changed over the last few years. Of course, during the pandemic, we saw a huge influx in this space. However, with school-based services, it's been really, really untapped. Less than 4% of all schools use telehealth services at all. And there's been a lot of pushback in regards to that, but given how school shootings and gun violence and a lot of these big topics we hear at a national level have kind of unfolded, there's a really interesting timeline, because as ESSER funding has kind of come in, you know, now it's being replaced by school-based service funding available from CMS. So this has been a really big conversation point, where being able to understand what schools are going to be able to bill for right now, like there's a lot of question marks. So as these funds are kind of disappearing, like what was available during the pandemic, there's a big push for schools to be the ones to handle this mental health crisis for young people. However, there's almost no support that's provided to these schools. And sadly, although, you know, urban districts as well as urban and suburban districts have a lot of help and support to be able to access these services, traditionally rural districts have been incredibly disadvantaged in having grant support and knowing how to go through the process or what are the deadlines for grants in their area. So a lot of when we talk to schools, a lot of what we're doing is actually assisting them with the grant process and making sure they understand what resources are available, not just in their state through the Department of Education, but also philanthropists, as well as, you know, big campaigns that are going on to support students. And this is just a little bit of one of our programs.
Welcome to Sisu, a subclinical platform designed to empower teens to develop mental health skills and cultivate resilience. To get started, each teen will fill out this quick form. If they're affiliated with a school or organization, they will enter a unique code associated with their institution here. Here, teens can see that we take their privacy seriously and will never sell or share data without consent. Once onboarded, teens can select a program and complete a self-reported assessment focused on their social and emotional skills, such as self and social awareness. To monitor progress, a post-assessment will be conducted. Next, teens can invite their caretaker to join the platform. On the homepage, teens can access their weekly gems, program content, and dedicated care team. The 12-week program includes engaging content, with each week consisting of 10 to 15 minutes of reading, videos, and reflection questions. Videos are group discussions led by Dr. Jennifer, featuring teens sharing their experiences on our program topics. Weekly gems prompt both teens and caretakers to respond to a relevant prompt based on the week's content. The responses are only revealed once both parties have submitted their own, thereby initiating meaningful conversations and creating a shared language. Lastly, teens have access to a real-life mentor with a crisis prevention background and shared experiences who will initiate chats with them at least once a day. Parents can schedule up to 3 one-hour-long calls with their licensed family support specialist with the opportunity to steer the direction of the conversation. Teen participation in these calls is optional and can be accessed here. Thank you. Welcome to Sisu, a subclinical platform designed to empower teens to develop mental health skills and cultivate
If it'll let me skip this slide. So, this is a little bit about that MTSS system. Most schools, not all, but there's been a lot of systems similar to this, which is how schools identify students needing additional support or referrals out of the district. Needless to say, within digital mental health, if you are a service provider working with, let's say a large company, typically a utilization rate is 3 to 5%. It's extremely small. Schools, that tier 3 support, meaning the highest level of support a student could reach, it used to be around 5%, but with the pandemic, we've actually been talking to schools that are reporting up to 30% of their students falling in this category. So it's been really interesting to talk to counselors and people who are dealing with students again and again and again. Those frequent flyers that I believe Robert mentioned, that the need is really increased quite a bit since the pandemic. In terms of just what this landscape looks like, of course, there's a lot of teen-focused mental health supports out there, but when you actually look at what programs are typically available for schools, the 2 largest companies that are out there is really Hazel Health, and there's another company called Daybreak Health. A lot of companies focus more on the analytics side rather than providing direct services. And actually, a lot of the programs have had a lot of issues when it comes to privacy because although, schools have a lot of liberty to be able to know what students are doing when they're on campus, it's when they're off campus that the school districts can become liable for issues with students, even though they don't have any way to obviously monitor what's going on. On a school side, this is typically how we engage with a school. So really it's just setting up calls. Typically we're dealing with the superintendent if it's done at a district level or the principal or dean of mental health services. We always involve the parents in our onboarding process. So outside of course, gathering consent from the families, we also do like mental health nights where they can ask questions and hear more about how the family wants to interact with the platform. And some of the reason why we focus so much on the parent and we contact the parents a lot as part of our, pilot process with school districts is because if you look at how family mental health is delivered, if you can support the adults, automatically there will be benefits to the child across the board. And so needless to say, many schools do this in a few different ways. So some schools want to deliver this during like advisory period or their homeroom. Other schools, because they're on a 4-day week, they want this to be a resource that the students can use when they're at home. All of our curriculum can be, delivered asynchronously. It's based on a browser. So as long as a school has like a Chromebook system, or public libraries, or depending on, if they have iPads, it's a browser-based system. It's also available in multiple languages right now. So we predominantly work with a lot of districts in English and Spanish, but especially in a lot of different refugee communities, we've had a lot of requests to have content delivered in specific languages as well. This kind of is are some of the results that came out of our first pilot we ran. And just to give more context, we launched this in March. So this is really, really brand new. Some of the topics that we have curriculum around is self-esteem and confidence, bullying and violence, healthy identities, digital citizenship, grief and loss, and managing anxiety. The Templeton pilot, the school was a private school based in the Nashville area. What was very startling about the implementation was this was a school that was impacted by the shooting in Nashville. So as the students were using the platform, some of their students and friends had passed away in the community. So understanding how this actually can be used, not just by the students, but also teachers and principals and anyone who is impacted by these situations that can go on in schools, was really key to understanding what the dynamic within a building is like, and being able to provide the right support at the right time. This is a little bit of our core team of who's been working on this. One of my teammates worked with me previously at Aona Therapy, and Dr. Smith Collins is known within the equity space within social and emotional learning, and Mr. Love is actually a former NFL player who's been in the K-12 space most of his professional career. One thing that I think would be really helpful is I'm from the Kansas City area, but I have not been, I've been all over the place, and needless to say, we've done some events for our go-to-market strategy. So we did USA Kansas, which is focused on the Kansas side administrators, and we're doing one in Missouri down in Columbia this Sunday, actually. But if you have anyone who works with schools, I would love to talk to them. And one of the things that we're prioritizing for this fall is actually helping families who are, Medicaid or Medicare eligible get signed up for services, so it can reduce the cost required for a school. So if any of you have expertise around these areas, I've been talking to a lot of people, and we would love support in that sense. I don't know if you have any questions, but would love to answer anything.
No, that's great, Erin. Thank you. I have kind of an immediate question, and you just touched on it a second ago, and that was about who really pays for it? Who's the client?
So typically the client is actually the school district. So for instance, we often are working through like the grant process. So a lot of schools are eligible for REACH grants, or through different opportunities through like the Bipartisan Safety Act. So for instance, we just received a grant from several different counties around Indiana, that, this is what they applied for and how it will be implemented. But we often work with a school and build a needs assessment based on the school having funding or not, or knowing what the makeup is. So on our side, if we know a school doesn't have the ability to pay themselves, we work with and find resources for them.
Is it Templeton that was your case that you showed? Are
Yeah.
those what you would typically use as metrics? What you showed in the grid?
Yeah, that would be, a metric for a private school. Obviously, every school has their own uniqueness that comes with it. Where it gets really challenging is, so for instance, we're piloting in Chicago public schools right now. Chicago, obviously, we're in the south side of Chicago and the west side of Chicago. And a lot of times we're working with community partners as a big part of our strategy. So the near peer mentors we work with and train, sometimes they're physically going to the school. If we're able to build that relationship where someone is able to kind of have a face with the name, it's really important to get students engaged. And feeling comfortable confiding in these people in an online manner. The more comfortable you can get families as well as the teens with these individuals, the better engagement you're going to have. So it kind of depends on the laws in the state. For instance, in the state of Texas, you can't send anyone into the school. So there's a lot of different legalities to know about every different implementation, and it can end up changing a lot on what the data looks like and what you're able to do.
Yeah, that issue of regulation seems to be really crucial.
Mm-hmm.
We have one question from Evelyn Nelson. Great presentation, appreciate the focus on relational health. How do schools share the opportunity with students and families?
So typically what a school does is they provide that tier 1 curriculum. So the curriculum that I showed like a little sample of, they're implementing that within the school system. And then either the family can get referrals where we're able to work with the family as a whole on the support service side, or if the school has budget for it, they often will pay for that tier 1 support. I would say that most of the time the schools have the ability to pay. It's really in rural schools that there is a big need for additional resources being brought to the table. But typically in a Title I school, there's a lot of support available to students.
Other questions?
Yeah, this is Teresa. Hey, quick question. Is it possible for the schools to negotiate a lower insurance premium if they institute your system?
Yeah, so for a school, the biggest value prop is saving them money or getting them assistance in terms of procuring LCSWs. That's a big win for the school. We have been developing case studies around saving costs on their premiums, because effectively we can be that in between where some of the liability gets shared by us. For a school, that's the number one reason why, they're interested in this platform, for sure.
That's it. I would never have considered that. That's very interesting. Other thoughts? Aaron, what sort of penetration do you expect to get within a school? Is it 100% of the students, or just those who have been screened as at risk? What do you view as the balance there?
So typically after a pilot is typically done in, anywhere from 3 to 5 schools in a district, depending on the size of the district. Obviously, if it's a smaller, or it's at a site level, that can kind of impact those numbers, but it's typically the entire population. The whole point is being able to provide like an entire wraparound service, not just for the students, but their families as well. Where the school can kind of say, hey, go talk to these folks. This is who we're working with. They're able to support you. But those tier 1 programs are appropriate for any age. So we follow like the DESE standards depending on the state we're implementing in. And that's how we build out our learning model of the curriculum, and what our chief academic officer builds out for the curriculum. However, when it comes to those additional services, that will be depending on, does the school need more of that tier 1 support, or are they interested in almost, we call it overflow support. So for instance, if a school has a crisis and they know they need 30 providers you know, for at least a month. Being able to bring a huge influx of providers in any school can be really, really difficult, depending on what's going on with the community. So I'm sure you can imagine if those are the kinds of implementations we have a lot in that tier 1 space and a lot where there's like a really, you know, high risk emergent situation going on.
How do you bring that sort of resource to bear?
So that goes a lot to how, so our platform is subclinical. It can be implemented in a clinical sense based on having the consent from the family. So we are not diagnosing children. We are able to identify children who have high risk needs. However, we're not, you know, handing out medicines. We're not doing any of that more clinical side of care. So we do have a team of licensed providers, and some of this is our assistance with the Blue Cross network. We have ability to access a lot of different networks of providers, but if you are using therapists as coaches effectively, you have the ability to come in and support students in a really, really unique way. But it does depend a lot on what's going on. So there's really clear cutoffs of like, okay, this is a clinical sense versus a subclinical sense. And what does that mean? And making sure that schools understand what levels of support are needed at what point. So for instance, even within that tier 3 implementation, once a student has been identified as having like serious mental illness, that is a completely different setup. Most digital mental health platforms do not work with individuals with serious mental health. And those are situations where you need to be doing inpatient or have your referrals set up. So we do set up, obviously, a lot of partnerships with the community. So for instance, in Chicago, we work with like Cook County Mental Health Association. We work with, you know, a lot of different hospitals. We always make sure that there's additional levels of support in case a student needs to have like a higher level of support.
That's remarkable. Other thoughts from the team? Well, let's go ahead and leave it at that. Aaron, that was really very interesting and amazing how complex of an environment you're managing. It's really remarkable. So thank you so much for sharing with us.
Thank you.
And to say to the team, thank you very much to everyone. Really appreciate your participation and input and look forward to seeing you next month and beyond.
Thank you, John.
Thank you. Bye now.
Take care.